I am an emergency physician trained here in San Diego, California. I've been working as an ER doctor now for 15 years out of residency. And several years ago, I've always had a deep interest in resuscitation and improving resuscitation, mainly because most of you know, if you suffer an out-of-hospital cardiac arrest, your chance of survival from that walking out of the hospital neurologically intact is in single digits. It's like 8 to 10%, depending on where you live. And so with that being dismal numbers, my colleague and I, a gentleman named Zach Shiner, decided to look at this technology of implementing extracorporeal membrane oxygenation, or the other term is ECMO, and more specifically veno-arterial ECMO, VA ECMO, in patients who have arrested. And so that started in 2010. And I can tell you that story if you like. It's not glamorous.
Sure.
And after that, we started this ECMO podcast, which was a goal to enhance understanding of this technology and how to use ECMO in cardiac arrest. And the journey that we've been down in doing that has taught us a lot more than we ever expected to know. And so we've now become, not purposefully, but we have become, I guess, some of the world's experts on implementing ECMO in the emergency department by emergency physicians for patients who are arresting.
Yes, that's a very, very rare breed, I must say. So just tell us how you start, this ECMO in ED. It seems.
Sure. So this is not a glamorous story, but it's one that I've told before, and it's not anything I'm trying to hide. But years ago, in 2010, I had a patient who was 59 years old who had a pulmonary embolus, and she came in talking, and she slowly died in front of me over like 2 hours. It was horrible. Massive PE. We threw everything at her, and she didn't survive.
Okay.
So moments later, or a day or two later, I was in the doctor's dining rooms just chatting with one of our CT surgeons, the guy who runs our CT surgery department. His name is Walter Dembitsky. And I asked him, is there anything else I could have done in this case? And he got kind of angry at me and said, "Why? I don't understand. Why did you not start ECMO?" And my answer was, because I thought ECMO was for babies with who had bad lung problems and premature infants, and I didn't even know you could start ECMO on an adult. Now this is
the years. What is the year? Again?
2010.
Okay.
So 7 years ago, I was, being a dumb old ER doc, I had no idea that upstairs they're doing veno-arterial ECMO for support of, post-heart patients. And then also sometimes in crashing CPR patients in the ICU, there are places that have been doing ECMO for 20 years now, and I had no idea. So I thought that was a bit of a neat idea. Maybe we could implement this somehow in the ER, because the ECMO machines that we use are all very mobile. So flash forward, smash cut to a month or so later, and Zach Shiner, my colleague, gave a talk to our group. This is a Wednesday. I know the date specifically. It was July 28th, 2010. And I'll tell you a story as to why I know that date. But Zach gave a talk on implementing veno-arterial ECMO in the emergency department to our group meeting on July 20th, 2010. We all rolled our eyes and thought there's no way we would ever be able to do that. Then move forward. That evening was about 5 o'clock at night, and I am again down in the doctor's dining room. I seem to spend a lot of time in the doctor's dining room, and I got a call on a little phone that we carry with us, and it was Zach saying, "Hey, I've got a 59-year-old guy coming in arrest, and come on down to the ER. I'll run the code, and you can put him on ECMO." Now, at that moment, I had never seen an ECMO machine. I had never seen an ECMO cannula. I have no idea what it was. But I run down to help him with this resuscitation. And this guy was a gentleman that had chest pain. He had an ST elevation myocardial infarction by medics. And then en route, he went into VFib. So Zach got, we moved him into the room. We transitioned him over to our gurney, and Zach started the resuscitation process. And then basically yelled at me that I needed to start ECMO somehow. Well, all I really knew at that point was from Zach's talk earlier that day. And by the way, as an aside, I'm not suggesting you learn ECMO this way, but this is what happened. I'm just being honest. So based on that talk, I knew I needed to get femoral, venous, and arterial access. So I did that with the catheters that we have in the ER. There's a 5 French Cook in the artery and a 9 French cordis in the vein. And fortunately, in that case, we had our ECMO, the nurse who trains all the ECMO nurses, the head of our ECMO program, happened to be the nurse on call who brought the ECMO machine down to us. So in the course of the resuscitation, I was sort of taught in real time to dilate. And now bear in mind that at this point, the patient, by the way, his name's Ralph. He knows, he's given full permission to allow us to tell this story. But Ralph was down now for about 45 minutes. And in most ERs at this point, we're going to stop resuscitation.
Yes.
We've gone this far. He's gotten probably 5 or 6 rounds of epi. He occasionally pops into a sinus rhythm and then back into VF, and just wasn't responding well. So I cannulated and got lines in, and we get to the 60-minute mark, and Zach's contemplating pronouncing, and we think, well, what have we got to lose at this point? All right, so this is a free shot, sort of. Most people would pronounce this patient dead.
Yeah.
So, heroically, I announced that we were going to turn on the machine, and we did, and at which time the right groin kind of blew up. There was blood that spewed everywhere. Okay. And I'll jump to the punchline, but what had actually happened was that I had cannulated his femoral artery, and then back walled the femoral artery, so the cannula was in his retroperitoneum.
Ah, okay.
So when we turned the machine on, there was a little bit of advanced back pressure and blood poured out. So we stopped that, clamped the lines, and still now we're at 68 minutes of CPR. At which time, just happenstance, our trauma surgeon walked by and asked if we needed any help. Being that there was blood everywhere, he assumed that this was trauma. And I asked him if he'd do a cut down of the left femoral artery, and he did. And we put wires in, and now we're approaching 70 minutes of CPR, and we finally get Ralph onto machine, onto pump. And now everything's working fine. We've got good flows, 5 liters a minute, good flows. All our numbers are looking better. It's pinking up. But 70 minutes of CPR, that's a dead guy, right? So it was a STEMI, if you'll recall. So the cardiologist rolled by and looked at what we'd done and said, 70 minutes out, that's not survivable. And he left the hospital. And then we put Ralph upstairs in the ICU, assuming that there's no way that this guy's going to survive. And then about an hour later, he started to move. And then he started looking at his watch, and he started really like opening his eyes and bucking the tube. So we called the cardiologist back, took him back to he came back to the hospital. They took him to the cath lab, and he had a 100% LAD stent, a lesion that they stented. And it turns out that Ralph had a very good outcome. He walked out of he wouldn't even take a wheelchair. He walked out of the hospital 9 days later. So that was a proof in our minds that, number one, prolonged resuscitations can be recovered on ECMO. And number two is don't stop, because you just never know for sure. And number three is emergency doctors can put somebody on ECMO. And now we just need to learn how to do it properly. So that's when we went back and started sort of our own personal training with our CT surgeons, and realized that there's a huge gap in training on this kind of a thing. And it's conceptually a relatively easy thing to implement, ECMO, but it does require a bit of training. And so we started 2 things. One was the ED ECMO podcast, where we have monthly lessons on how to do these things. And the second was a program that we run a conference here in San Diego called Reanimate. And that website, if you want it, is Reanimate Conference, all one word, reanimateconference.com. And the next one's coming up in September. This isn't an advertising for that, but that's what we do. And we teach the hands-on and simulators and, pump management and all that kind of stuff. So that's the long story of the evolution of where I got to where I am now.
Thank you very much. It's very honest and very inspiring. I never thought that would be, but
the story. Yeah.
Yes. And so I'm asking as one of the ER. I mean, we all know how to do, central line, that stuff. But when did you train to do like the dilation of the ECMO cannula? Because it's got to be a different kind of skill, right? Because it's different dilators, different size. I don't know. I mean, what do you do? Or you just, I don't know.
So, I don't want to underplay the significance of putting somebody on ECMO. It's huge dilators, and it is central lines on steroids, so to speak. The typical lines that we put in is going to be, so when you put in right now as an ER doctor, Tong, when you put in a central line, you're putting in probably about a 9 French, somewhere in there in the vein. And then if you're going to put in an arterial line, you're probably going to put in a 5 French or smaller. I think most people are moving to 4 French micropuncture catheters for arterial access because it causes less arterial damage. So that's all fine and good, because a 4 French hole in the femoral artery can easily be, you can just put a pressure on afterwards if you take it out, and it doesn't require repair. But you get any bigger than that, and you're starting to get into the world of needing repair of that femoral artery. So you don't want to do this willy-nilly and end up having to repair a lot of femoral arteries. You're going to anger your vascular surgery team if you do that. So, you really have to pick and choose these, and understanding that once you get somebody up onto veno-arterial ECMO, your venous cannula on average is a 21 French, and your arterial cannula is a 17 to 19 French. And remember, comparing that to like a 4 French. So lots of vascular damage can happen. It's not a procedure for the faint of heart. But on the other end of the spectrum, if you think about it, where ER doctors are doing this is not in semi-elective situations. We're talking about doing this in patients who have already failed ACLS. So here's the beauty of it. If you have a patient who comes into your emergency department right now, Tong, and they're getting chest compressions, so they've arrested in the field. They've already had 15 minutes of chest compressions, and they're not responding, or they would have shocked them out in the field. So those patients aren't going to respond typically in a prolonged arrest like this to any more shocks. Rarely you might get somebody back for a while, but most of the time the shocks aren't going to work anymore. They need perfusion of their coronaries, and they need whatever caused them to arrest, meaning a coronary lesion or a pulmonary embolus or an overdose. They need all that to go away. And so you need to buy these people time, right? So the fact is if a patient comes into your ER right now and you try to cannulate the femoral artery and femoral vein just for resuscitation, by the time you're done with that, that patient's had 30 minutes of CPR or so. And then as you walk that down, if there are any difficulties getting those cannulas in or getting in your catheters, that could be 45 minutes. And so it's at that point right now, you've got a patient who has arrested, they're in VF, they're getting CPR, you've put in a femoral art line and a femoral vein line, and you're using those for resuscitation. And on average, you're already at the 30 or 45 minute mark. So what are the chances of that patient surviving that in traditional ACLS? Exquisitely low. So it's so low that you can say, and at that point, the patient's already received 3, 4, 5 rounds of epi, multiple shocks, and if they're still doing CPR, then everything's failed. So in most situations in your ER right now, you're going to pronounce that patient. So if I'm going to cannulate that patient starting at that time 0, then I'm cannulating a dead person. In other words, they failed ACLS. Everything else has failed. If I end up backwalling the artery, if I end up not getting them on ECMO, there's really no harm here because that patient was going to die anyway. You were going to pronounce that patient. So, I don't want to downplay the significance of putting somebody on veno-arterial ECMO, but at the same time, your risk is very low because all these patients are going to die.
That's I never thought of that. It's a very good to pump up before you go into the field. Very good, actually. And I must see what I'm going to ask you.
Sure.
So when you activate, let's walk the audience through when you activate the ECPR. Did you activate when you know that somebody is going to come into your hospital from pre-hospital, or just when you start CPR for 15 minutes and then you thought, oh, maybe this is
Yeah. So we get a notice that through our radio room that there's a patient coming in CPR in progress. And once we get that notice, there are a couple of initial quick decisions that are made. If they're coming from a nursing home and they're 98 years old, we're not doing anything.
Okay.
So let's take the other extreme, the easy one, and that would be a 55-year-old who clutched his chest, went to the ground, is in ventricular fibrillation, and medics are bringing them to me. If that's the story that I get, or something in that world, then I will call our ECMO team, which in our hospital, our nurses run the initial ECMO. So once a patient goes on pump, we have a nursing staff who runs the first hour of ECMO until the perfusionists get there. We have perfusionists on call who will come in and are expected to be there within the hour. So that first hour on pump is managed and whatever the word is. All that's done by nursing and doctors in real time in that first hour. So what that means is that in our ICU, we have always 2 nurses who are ICU nurses who are cross-trained in implementation of ECMO. And so they're always available, and the machine sits in the ICU because most of the crashing patients that they use ECMO on are not going to be ER patients. They're going to be post-op patients or heart failure patients in the ICU. So that's where it needs to be. But it's a mobile cart. And so it's a mobile cart on wheels, and they have a trolley that has supplies on it. And so there's 2 things that can be rolled down to us. And if I call for the ECMO team on a out-of-hospital cardiac arrest, they're usually in my ER before the patient even shows up. They're that fast. It's a 5-minute call time. So it's very quick for them to get there. And then I think your next question is going to be, okay, so they're sitting there, and then the patient rolls in, and they look like they're a candidate, and we're going to start the process of implementing ECMO. There's a choreography that then occurs that I can send to you at a later date on how we move the patient into the room and how we move them over and how we quickly access the femoral vessels. That is a very specific process that would take 15 minutes to walk you through, and I won't bore your listeners with that right now.
Okay.
But needless to say, the patient comes in, they get moved over from the medic gurney to our gurney. I then begin the process of cannulation.
Okay.
That process is a 3-step process, and there's a reason for that. The first step is just what I told you earlier, Tong. Is patient comes into your ER, they're arresting, and what are you doing as an ER doctor in your hospital without ECMO? And that's airway, chest compressions, shocks, and then sometimes you'll access the femoral vessels to get central access. And so that's what we do is central access, 9 French in the vein, 5 French in the artery. And then once that's done, there's a hard stop then. In other words, the doctor who's doing the ECMO procedure will then stop for a moment. There's a doctor, I'm sorry, I didn't explain this. This is a 2-doctor process.
Okay.
One doctor manages the airway, and then that doctor steps out of the room and gathers information, while the second doctor, the line doctor, is got one task, and that's vascular access and cannulation.
Okay.
And as a quick aside, if you were to go I was just interviewed by one of my good friends, Scott Weingart. I think you might know him. Scott runs the MCRIT podcast, and he just published a discussion with me on how we choreograph those first few minutes of a code. And that episode, hold on, I'll pull it up for you right here, is podcast 204. So if you go to mcrit.org/204, the description there is called the nurse-led code. And what that means is that our nursing staff actually does the mechanics of running our CPR codes in the ER so that doctors can focus on decision-making and cannulation.
Ah, okay.
So the next question I think you probably have, I'm sorry, I'm running my own interview here. I don't know if you noticed this. The next question I think you'd have is, do you pre-prime your cannulas? Do you pre-prime your circuit? And the answer for us is no, although I will say that most places do have a pre-prime circuit, meaning that the circuit is filled with a saline solution. We use something called isolite, but a crystalloid solution is throughout your circuit. The tubing, the oxygenator, and the pump head all have fluid within it already. The problem with pre-priming your circuit is that if you do that, you have 30 days to use that circuit, or you have to discard it. Those are just the rules that somebody else made. And so there might be situations where we could go 30 days without using a circuit, and then that's a couple $1,000s thrown in the trash. So we don't pre-prime. And another reason that we don't pre-prime is that our nursing staff, I was talking earlier about the ECMO nurses, are so fast and they're so good that they have the circuit primed before I have finished cannulation.
Okay.
They're so fast. So they can do it right then. If I say go, it takes them about 5 minutes to prime the circuit completely, and I'm still working on cannulation. So that's how it works. We'll call for them in the pre-hospital setting. They'll come down, they'll wait. They don't prime the circuit yet. They'll wait until the patient rolls in. I will then look at the patient, gather the first 30 seconds of information, and then I know it's a go or it's not a go.
Okay.
We then start the process of cannulation while they're priming. I'm just putting in a 9 French and a 5 French. At that point, I stop and I turn to the doctor who's running the code and say, is this still a candidate? Because we might find out now that, well, this is actually a patient who has terminal cancer and they never wanted any of this, blah, blah, blah. But if it is a potential candidate, then we move from stage 1, which is just those catheters, to stage 2, which is cannulation. So then we pass dilators. So we're using, we can talk about brands if you'd like, but
Sure.
we pass dilators. I'll pass in a couple of dilators and then put in the cannula that is going to go in, usually about a 19 French in the artery and a 21 French in the vein. And after I've finished that process and the nursing staff has just completed the priming process, I'll clamp those cannulas. Again, we have a hard stop.
Okay.
I look up at the doctor and say, has any more information come in? Is this still a go? And I've been focusing on the groin. The other doctor's focusing on whether or not this is a candidate and what caused the arrest. So at that point, if it's a go, we connect the tubing from the cannulas to the circuit tubing and turn the machine on, and then start the process of troubleshooting the machine and making sure flows are good and that kind of a thing. And then your patient's on ECMO.
Okay. So, I have 2 questions. Now you can guess it. So it's a layman question. So this is totally, dumb. But so when you puncture the patient, is the patient still on chest compression?
Ooh, that is a brilliant question. It's not dumb at all. I think when we first started this, I know, when we first started this, we were doing chest compressions during cannulation. And that's not a big problem for the vein. Yeah. But if you're an ultrasound person, and so I task you with this. Sometime when you have an extra doctor around, take your linear probe. When somebody comes in arrest, do it on a person who is not probably survivable. The nursing home patient we were talking about earlier, and just take the linear probe and put it on their groin and measure the femoral artery and femoral vein. And then let CPR happen, and then right before you're going to call the code, measure the femoral artery and femoral vein again. And what you're going to find is that once a patient has arrested, over the next 15 to 20 minutes, their venous system and their arterial system equilibrates in terms of pressure. But the venous system is such a big capacitance system that the femoral vein starts out normal sized. And as the arrest is prolonged, that femoral vein appears to become bigger and bigger and bigger because that capacitance system is pressure equal to what's now in the arterial system, which is right next to it. And that artery, which was right next to it and maybe a third of its size, is now you almost can't even see it anymore. It's so tiny, and it appears to dive down behind the vein a little bit.
Yes.
And so the point is every second that you wait in terms of cannulation, you're losing out on valuable time of capturing the artery. The artery is gold. The artery is everything. It's the hardest thing to do is cannulate the femoral artery under chest compressions.
Yes.
So then if you take that whole process and you give it 20 minutes and your artery is tiny and your vein is huge, and then you move that up and down, and now try and tap that. So you can get the needle into it, but it's going to pop right out, especially when you reach over for the wire and start trying to pass the wire and all that stuff. By that time, you've lost the game. And not only have you lost the game, but you've tapped the femoral artery, and now you've got a huge hematoma there. And now you can't do anything. And now your next step is cut down, which has its own set of problems. So how I do this is there's a little bit of a technique. So I take the tip of my needle after the artery first. Okay, so I've got a 5 French Cook catheter set next to me. The patient's getting chest compression. I take the tip of my needle and I just pop it into skin, just so the tip is in skin. Once the tip is in skin, and I can use ultrasound and I can see the femoral artery and femoral vein, and I can see that the tip of the needle is kind of pointing towards the femoral artery. At that point, I ask for chest compressions to stop. So chest compressions stop. I go in using ultrasound guidance into the artery. Okay, grab the needle, take the syringe off, pass the wire in, needle comes out. So now I have a wire in the vessel, and now I yell or say, please restart chest compressions. Now I have a wire in the femoral artery. And after that, the rest is
Doesn't matter
relatively
now.
easy because
Yes.
now I've got a wire in there, and I then have a way of getting into the vessel with dilators.
Okay. I think that's a very important question for beginner. I think.
Yeah.
And another
But-
one is yes.
Just remember that in ACLS, the mantra is never stop chest compressions.
Yes.
And that is absolutely true. So never, ever, ever stop chest compressions if you're doing ACLS. But if you're doing ED ECMO or VA ECMO or ECPR, you've gone beyond the scope of ACLS. And
Yes.
so at that point, ACLS buys you an 8% recovery neuro intact in the US.
Okay.
ECMO, if you look at all the studies that are out there, ECMO buys you somewhere between 25 and 30% recovery.
Yes.
So ED, ECPR has much better outcomes than traditional ACLS, which is why I say that, and I have no data to back this up, but I say that we should stop chest compressions for 30 seconds or so while I'm getting the wire in. And actually, in honesty, it probably takes 10 seconds. But needle in, wire in, needle out, start chest compressions, and that process seems to work really well. And now you've got somebody who's heading down the ECMO pathway, not down the ACLS 8%, or what is that, 92% death pathway.
Okay. We have to maybe censor this part.
Oh, no, don't censor that. That's fine. I don't have a problem with it. It's true.
I agree. I completely agree. That's why we have this interview. Yeah. Because I think it's the regular pathway. The reason I asked is because when I try to puncture, I experience the same thing. But when I puncture, it's just for something like severe hypovolemia, that kind of stuff that we need to actually have centralized. And I find it's really hard to actually do it while chest compression. But we are branding to we have been inception, right? Not to stop chest compression, but sometimes it's really hard because we need to put in something. Another thing is about the catheter. Mm-hmm. So again, beginner questions. So when you said you put in the small catheter first, the 9 and the 5, mm-hmm. and then after that, this is catheter, not guide wire, correct?
Correct.
And then after that, when you put in a larger one, how do you transfer? You put in guide wire and then you dilate again, right?
Yes, really good questions. So what you've just completed is what we refer to as stage 1 of ECMO, of ECPR, or what you will just call good resuscitation, which is putting in that 9 French and 5 French in the femoral artery or femoral vein and artery. And so now you've got 2 nice catheters sitting in there, and chest compressions are still going on, and the patient is still in VF, and you're still going your usual ACLS, shock, epi, chest compressions, shock, epi, chest compressions. So now you've made the decision that you want to dilate up. Okay, you're going to put in these ECMO cannulae. So there are several types of wires that you can use. The wires that come in most ECMO cannula kits were not contrived. They were not designed for percutaneous access. They were designed for cut down.
Okay.
So they're very flimsy wires. But the good side of a flimsy wire is that if you pass it up and get it up into the right atrium, flimsy wires don't cause much damage.
Okay, that's true.
But the problem is, especially in the U.S., I don't know how it is in Thailand, but in the U.S., people are more portly. Men can get up into the 350-pound range, and that's a lot of adipose tissue you got to get through.
Yes.
And deep to that adipose tissue is a nice thick layer of fascia, and that fascia can sometimes be tough for passing dilators in.
Okay.
So what we've transitioned, my practice is that I have a 9 French and 5 French in, and then I use I don't know if you're using brand names on your podcast, but I use Amplatz Super Stiff or Amplatz Extra Stiff. That's AMPLATZ, Amplatz wires.
Okay.
There are several different types. There is a Teflon coated floppy tip, which is the one that I usually use. There's also a J-tip wire. But the point is that the tip is very floppy and malleable and won't cause damage, but the back end of that wire is very stiff. And you almost have to pick up one of these wires and play with them. And if you have a cath lab, go up to your cath lab. They use these things all the time. You can just ask for an Amplatz Super Stiff. You want to use a 145 centimeter long wire. There are longer ones that they use in the cath lab. The 260 centimeter wires they use in the cath lab, those are too long for ED purposes. And in fact, Zach took one of those wires and stood on the roof of the second story home and held it over the edge, and it touched the ground. to explain to you how long these guide wires
Really
are.
long.
That's the 260.
Okay.
But the one that we use is the shorter version, is a 145 centimeter Amplat super stiff guide wire.
Okay.
So I have two lines in. I then open up that package for the Amplat super stiff. I pass it into the femoral artery catheter, and then begin the process of dilation. That process is usually, in most cases, 2 sequential dilators. It'll be like a 12 French and then a 14 French, and then I'll put in a 16 or an 18 French cannula. And the cannula is the cannula itself, and it has an inner dilator inside of it, an introducer, if you will. And so that whole thing will then pass over the guide wire and into the femoral, well, I was just talking about femoral artery or femoral vein, depending on which one you're going after.
Okay.
Does that make sense?
Yes, of course. I was, so does it bleed a lot? I mean,
yeah, lots of bleeding. The femoral vein doesn't as much. The femoral artery bleeds quite a bit. You just kind of have to get used to the fact that there's going to be a lot of bleeding. It's not easy to do one of these cases and not have a lot of bleeding.
Okay.
It's just the nature of the business.
Okay.
You know, these are giant holes you're putting in these vessels. And, you know, as ER docs, we're doing this blind, and at times we hit one of the vessels, and then for whatever reason, somebody starts chest compressions or whatever happens, and you sometimes lose the vessel and you have to go back in again, and you might have 2 or 3 pokes on that vessel. Not ideal, and that's going to be a bleeding complication down the road as bleeding happens around that vessel. But it does happen. I mean, that's just honesty.
Okay. Okay, let's see what else. I think we cover, hold on. Okay, so do you do, okay, another question. So do you do VV ECMO or no?
Really good question from an ER perspective. So for your listeners, and again, I'll go to beginner, like you say, VV ECMO is a pure lung bypass. You're not getting any of the benefits of the cardiopulmonary bypass. VA ECMO is cardiopulmonary bypass. So in VA, for simplicity's sake, VA is a cannula in the artery and a cannula in a vein. You're sucking all the blood out of the right atrium through the venous cannula. You're pushing it all back into the artery, up into the aorta retrograde after it passes through the oxygenator and the pump in the ECMO circuit. VV ECMO, you're coming in, you're taking blood out of the femoral, or usually out of the IVC or SVC, and you're passing that blood back into the body, back into the vein, and delivering that right at the inlet of the right atrium. So with VV ECMO, you're using your native heart as the pump, and blood is circulating antegrade. In VA ECMO, you're taking the heart and lungs both out of the picture, and you're circulating the system retrograde, which can create a whole different set of problems that we can talk about at another time.
Okay.
So generally speaking, if you can get away with VV ECMO for some reason, and you don't need the heart bypass, then that is probably a better option if that's in the therapeutic benefit of the patient. In our patients in the emergency department who have arrested and they don't have a heartbeat, that's not an option. You need both heart and lung bypass. So 99% of the time we are putting patients on ECMO in the ER, we're doing VA ECMO.
Okay.
Now, and because, you know, 99% of these patients are patients who have a STEMI heart attack and go into VF arrest as a result. Even with PE, which you'd think is a pure pulmonary issue, a lot of the problem is mechanical shock and subsequent vasoplegia. So putting them on VA ECMO is usually what you have to do with PE. But we've had a couple of cases, and the probably most classic case that we had was a patient, a 22-year-old guy, who had the worst case of anaphylaxis we've ever seen. It was so bad, his lungs were so tight that we could bag air into his lungs, and then the doctor had to lay on his chest to squeeze all the air out of his chest. And so his CO2s went from 70 to 80 to 90 to 110 to 120, and then he started getting rhythm issues because now he's getting acidotic.
Yeah.
They couldn't. They had him on maximal pressor. They had him maximum epinephrine. They had him on all the usual stuff, steroids, magnesium, and nothing was working. And so at that point, the decision was made to put that guy on VA ECMO, because really what we needed to do was dialyze his body of CO2. because the rising CO2 is what was causing his heart to get irritable because he was getting acidotic.
Mm.
So that is probably the one situation where you crash somebody onto VV ECMO is somebody who cannot ventilate. You really can't ventilate them.
Mm.
We had a case the other day of a guy that had angioedema of his neck, and fortunately, he arrested in our ER, and our trauma surgeon was helpful, and we were able to do a emergency tracheostomy.
Okay.
But had we not gotten in, a next option would have been VV ECMO, because that's an airway issue, pure airway. And so, yes, occasionally, rarely, we might do VV ECMO, but most of the time it's VA.
Okay. I think we cover all the layman topics in this episodes.
Sure.
Thank you very much for taking the time.
Thank you for having me on your show. Anytime, I'd love to be back.
Of course, when we are finished this show, and then we may gather some of the audience, because this is actually my hospital only and only my view. So thank you very much. This is Joe Bellezo from edecmo.org. And I hope to see you again sometime soon, Joe. Thank you very much. Anything you want to say to our audience?
No, thank you, Tong. And, get out there, resuscitate. People don't deserve 8%. They deserve